Hello everyone and welcome to our module on coronary artery disease. Coronary artery disease is the narrowing of a coronary artery caused by atherosclerosis. And you should know that atherosclerosis in a coronary artery does not automatically cause symptoms. Symptoms only occur when the plaque reaches a point that it occludes about 75% of the artery. So for example, imagine we're looking at a cross-section of a coronary artery. A plaque can obstruct a little bit of the area of flow and that will not cause symptoms. Only when the plaque blocks off about 75% of the area for flow will symptoms occur. And the classic symptom of coronary disease is chest pain, otherwise known as angina. Chest pain associated with coronary disease often occurs with exertion because that's when more blood flow is required for the work of the heart, and it often gets better with rest because at rest less blood flow is required. And in addition to chest pain, many other symptoms can occur due to coronary disease, especially dyspnea, but you can read about other symptoms like palpitations, sweating, and many others. And you should be aware that coronary artery disease exists along a spectrum. Patients who have plaques that obstruct less than 75% of the artery are asymptomatic. At the other end of the spectrum, patients with complete occlusion of an artery have what's known as a STEMI, which we'll talk about later. And in the middle, there are patients with stable angina, unstable angina, and end-STEMI. And all of these sort of represent a progression of coronary artery disease from the point where it's obstructing only a little bit of the area for flow all the way to where the complete area for flow in an artery is obstructed. Shown on this slide are the major risk factors for coronary disease. Diabetes and chronic kidney disease are the big ones. These are considered coronary artery disease equivalents. And what this means is that patients who have diabetes or chronic kidney disease have the same risk of having a myocardial infarction as someone who has a known history of coronary artery disease. These patients are in the highest risk category. We treat them as if they already have coronary artery disease. Other risk factors include hypertension, hyperlipidemia, especially elevated LDL is a risk factor. Age is a risk factor. Men over 45 are at higher risk and women greater than 55 are at higher risk. Family history is a risk factor, but only if there is a family history of premature coronary disease, and I've highlighted the word premature here. Patients must have a first-degree relative, meaning a mother, father, brother, or sister, with the onset of coronary disease before age 55 for a man or before age 65 for a woman. Lots of the patients you meet will tell you that they have a father or mother with heart disease in their 70s or 80s. That does not count as a risk factor for coronary disease. Smoking is a risk factor, and quitting smoking significantly reduces the risk of coronary disease. And then finally, obesity and a sedentary lifestyle are also important risk factors. So now let's talk about the clinical manifestations of coronary artery disease, and I'll begin by talking about stable angina. Stable angina occurs when there is plaque in a coronary vessel that occludes 75% or more of the artery. This is a picture of what it looks like on the screen here. There's an atherosclerotic plaque, but it has a stable cap. In other words, it is not ruptured and formed a thrombus. And blood flow can pass the plaque, but there is a limitation to flow because the plaque is obstructing so much of the artery. Patients with stable angina have what's known as typical chest pain. And typical chest pain always has the three features shown in the slide here. Pressure-like chest pain that occurs with exertion and is relieved by rest or nitroglycerin. Patients who have all three of these features are said to have typical chest pain. Patients who have features different from this are said to have atypical chest pain. In patients with stable angina, the EKG done at rest will be entirely normal. That's because there's no ischemia present at rest. Symptoms are also absent at rest, and that's because there's enough blood flow past the plaque to prevent the development of symptoms at rest. So if the EKG is normal and there are no symptoms at rest, the way that you diagnose stable angina is by doing what's known as a stress test. This is to ask the patient to exercise or otherwise subject the heart to stress and see what happens. And this is how we diagnose stable angina in patients where the diagnosis is not clear. So someone has all of these features, we often make the diagnosis clinically. But if we're not sure whether they have stable angina, maybe because some of their symptoms are atypical, then we always do a stress test. So let's talk about stress testing. First of all, just a general point. Stress testing is only done in patients who are asymptomatic. If a patient has chest pain at rest, we do not perform a stress test. And this is important to know for your board exams. If they describe a patient in the emergency room having ongoing chest pain, the next best test is not going to be a stress test. The idea with stress testing is to take asymptomatic patients and provoke ischemia and detect ischemia to make the diagnosis of coronary disease. The way we provoke ischemia is almost always through exercise. This is a preferred method, although for patients who are unable to exercise, there are alternatives, which I'll talk about in the next slide. This is a picture on the screen of a patient having an exercise treadmill test. The patient is hooked up to the EKG leads, and the EKG is being monitored while they exercise. Once we get the patient exercising and get their heart rate up, the way that we detect the ischemia is through one of a couple of methods. The most basic way is through the EKG. Patients who develop ischemia will develop ST depressions on the EKG. And I'll talk more about ST depressions later as a sign of ischemia when we talk about unstable angina. Now, we always monitor the EKG with exercise, but sometimes EKG changes can be difficult to detect, and in those cases, we use additional methods to detect ischemia. One common way to do this is through nuclear imaging, usually with the radioisotope called technetium. If you look at the images at the bottom of the screen, on the left side is a patient's heart at rest after injection with technetium. Technetium turns the left ventricle this orange-yellow color here, and it indicates areas of perfusion. And in this image in A, the entire left ventricle is yellow. That indicates normal perfusion to all the walls. At stress, the image on the right is obtained. This image shows that there's only perfusion to this part of the heart. At stress, the perfusion to all this area over here is diminished. That indicates that there is ischemia involving the artery that supplies the wall on the right side of the image. And that's how you use nuclear imaging to detect ischemia during a stress test. Finally, you can also do what's known as a stress echocardiogram. In this test, you look at the contractility of the left ventricle at rest and at stress. If a particular wall of the left ventricle becomes ischemic with exercise, it will contract less vigorously. This is called hypokinesis, and you can see this on the echocardiogram. For patients who are unable to exercise, there are two options for how to do stress testing. Reasons that patients can't exercise include things like osteoarthritis or neurologic dysfunction or sometimes severe back pain. The two options are a pharmacologic nuclear stress test or a dobutamine stress echocardiogram. A pharmacologic nuclear stress test is done by obtaining images just like we saw on the last slide. However, instead of obtaining them before and after exercise, you obtain the images before and after administration of a vasodilator medication. The vasodilators that are used include regadenoson. This is the most common one, but alternatives are dipyrimidine, adenosine, and persantine. And all these cause blood vessels to dilate, and that induces what's known as coronary steal. So let's talk about what that means right now. So let's imagine we have the LAD artery of a patient here. I'll write LAD. And then we have the circumflex over here, so I'll write the LCX. And then we have the right coronary artery over here, so I'll just write the letter R here. Now let's imagine there's a 75% plaque in the LAD artery. When you administer a vasodilator, the arterioles of the right coronary artery will dilate, and the arterioles of the left circumflex will dilate. However, the arterioles of the LAD will not dilate. That's because they are already maximally dilated at rest. That's what happens in blood vessels where there is a flow-limiting stenosis. So when you administer a vasodilator like regadenoson, the blood flow will increase to the right coronary artery, it will increase to the left circumflex, but it will actually decrease to the LAD because blood is being stolen away by the other vessels. This is called coronary steal, and it's a method of provoking ischemia in vessels that have a flow-limiting stenosis by stealing blood away to the other healthy vessels using a vasodilator. All of these vasodilators also can cause bronchoconstriction, so this can precipitate reactive airway disease and wheezing, and therefore it's generally a contraindication to administer one of these drugs to a patient who has significant COPD. The second stress test option for patients who can't exercise is a dobutamine stress echocardiogram. The idea here is to administer the drug dobutamine, which is a beta-1 agonist. This will increase the heart rate and contractility similar to what happens with exercise, and then you perform an echocardiogram at rest and after administering dobutamine. And if there is a blood vessel that has a significant stenosis, that area of the left ventricle will not contract normally after dobutamine. The downside to this method of pharmacologic stress testing is that dobutamine can cause arrhythmias, and these can develop in patients while they're having a dobutamine stress echocardiogram. I want to emphasize a very important point about stress testing. It can only identify ischemia caused by flow-limiting stenoses. These are plaques in the coronary vessels that occlude about 75% of the lumen. Smaller plaques, which are called non-flow limiting, are not detected by stress testing. So that means that even if a patient has a negative stress test, they can still have lots of plaque in their coronary vessels. And sometimes one of those plaques will rupture and cause an acute myocardial infarction shortly after a negative stress test. We see this all the time, unfortunately. So just because your patient has a negative stress test, it doesn't mean they're not at risk for acute myocardial infarction. It just means they do not have a flow-limiting coronary stenosis that is obstructing 75% of the vessel lumen. Stress testing is the way we usually make the diagnosis of coronary artery disease, but it can also be identified by angiography. Angiography is an invasive technique where a catheter is inserted into the wrist or the groin and threaded up the aorta to the coronary arteries, and then dye is injected. This will show you the anatomy of the coronary vessels, and you can see if plaque is present. If you look at this image on the screen, this is the LAD artery right here, and you can see that it narrows at this point right here. The reason it's narrowing is because there is plaque. So the dye, which is the dark colored material here, does not completely fill the vessel in this portion here. That's because there is a plaque there. So you can also make the diagnosis of coronary artery disease by angiography. Generally, we reserve angiography for patients who have already had a positive stress test. We do the angiogram, and then after this, we can perform an angioplasty, which I'll talk about later. Let's talk about the management of stable angina. First of all, you should be aware that these patients are at very high risk for myocardial infarction and sudden cardiac death. So one of the mainstays of treating patients with stable angina is preventative therapy. These are drugs that decrease the risk of sudden death from coronary disease and decrease the risk of myocardial infarction. And the two drugs always administered to all patients with any form of coronary disease for preventative therapy are aspirin and a statin. These drugs do not improve symptoms, they only prevent the development of more severe consequences of coronary disease. To prevent symptoms, there are a couple of things that can be done. First of all, anti-anginal therapy can be administered. These are drugs that decrease the myocardial oxygen demand to prevent the development of ischemia. Drugs used for these purposes are beta blockers or calcium channel blockers. They decrease the heart rate and the contractility of the left ventricle, and also nitroglycerin, which reduces the preload. Now, years ago, anti-anginal therapy was the mainstay of stable angina. In the modern era, we often treat stable angina with either a coronary stent implantation or a coronary artery bypass grafting surgery, and I'll talk more about these two things in a minute. You should be aware, however, that there was a famous trial that came out about 10 or 15 years ago called the COURAGE trial, and in that trial, they administered medical therapy like anti-anginal drugs and compared it to patients who got a stent or a bypass operation. And that trial showed that medical therapy had similar outcomes to stent implantation. So probably we should be using anti-anginal therapy more and coronary stent implantation and bypass surgery less. However, in the United States, these procedures are very popular and very common. The implantation of a coronary stent is referred to as a percutaneous coronary intervention, or PCI, and there are about 600,000 or more stents per year implanted in the United States. Stents have a chicken wire appearance like this. They're inserted into the vessel with a balloon that is collapsed. The balloon is inflated and it expands the stent, and then the balloon is deflated and withdrawn. And the result is that you take a vessel which has a significant plaque like this one at the top and convert it to one that has a stent placed with much better blood flow, and that usually relieves angina. For patients with more complex coronary disease that can't be treated by stent implantation, there is a surgical option called coronary artery bypass grafting surgery. We often just call it bypass surgery. And the idea here is to add a new connection to a coronary vessel from the aorta to bypass an obstruction. So let's imagine we have an LAD vessel here and it's got a plaque occluding lots of the lumen and causing angina. What the surgeon will do is attach a vessel to the aorta down to beyond the obstruction in the vessel. This will provide a new path for blood flow, bypassing the occlusion, and that will relieve the angina. Surgeons often use various vessels for the bypass grafts. One that is very popular is the left internal mammary artery, or the lima. Surgeons also sometimes take saphenous veins from the legs. This can be done without causing significant disruption to blood flow in the legs, and then they use the saphenous vein as a bypass conduit. Surgeons also sometimes take the radial artery out of the arm and use that as a conduit for a bypass operation. So here's a typical case of a patient with stable angina, a 65-year-old man who has chest pain while walking that is relieved with rest. He comes to the ED. Remember, in the emergency room, in stable angina, the EKG will be normal and the biomarkers will be normal. Biomarkers we'll talk about later, but these are elevated only in myocardial infarction. He's referred for a stress test. He walks on the treadmill. He gets chest pain and abnormal EKG changes. He has a cardiac catheterization, and a 90% lesion of his LAD artery is identified. A stent is placed and his angina is resolved. And then, of course, as we talked about earlier, he will be placed on lifelong aspirin and statin to prevent him from developing subsequent myocardial infarction. There are two complications of stent implantation that you should be aware of because stents are so common in the modern era, and also because these things will come up on your boards. The first stent complication is called restenosis. Restenosis is the slow, steady growth of scar tissue over a stent. This process is referred to as neointimal hyperplasia because it is a new intimal layer that is developing hyperplasia and growing over the stent. If the amount of scar tissue growth is significant, it can re-occlude the vessel. This can cause the angina to return. The good news is, because this is not an atherosclerotic plaque, it's made up of scar, it's rarely life-threatening. It usually doesn't rupture and cause a myocardial infarction, but it can cause the slow, steady return of angina. We don't see this that much anymore in the modern era, and that's because most stents are now coated with a medication. They're called drug-eluting stents. So the metal stent is covered with a polymer, and the polymer is impregnated with a drug that inhibits scar tissue growth. Often the drug is sirolimus, but there are other drugs that can be used. And by using stents that are coated with a drug, that generally limits the rate of restenosis, so that's relatively uncommon. Second complication of stents is called thrombosis. It rhymes with restenosis, but is a totally different problem and much more dangerous. Stent thrombosis is the acute closure of a stent with a blood clot. This is the same pathophysiology as STEMI. It's a life-threatening event. The metal in a stent can be a nidus for formation of a blood clot, and when that happens, the blood clot can completely occlude the lumen of the coronary vessel, and this will cause the same clinical picture as a STEMI. To prevent stent thrombosis, we always give two drugs that inhibit platelets. This is called dual antiplatelet therapy, and usually patients who have stent thrombosis are patients who miss dosages of their medication. So on a board exam, if they describe a patient who had a stent and comes in with a STEMI and the stent is occluded with a blood clot, most likely that patient missed taking a dose of one of their medications, and this is high yield to remember for your boards. So as I mentioned, to prevent stent thrombosis, we usually administer what's known as dual antiplatelet therapy. This is typically two drugs that are taken for a year after stent implantation. The two drugs always include aspirin and a second agent. The second agent may be clopidogrel, prasugrel, or ticagrelor. All three of these drugs are P2Y12 receptor antagonists that block the effects of platelets. The reason they're usually administered for only 1 year is because after a year, the metal of the stent is usually no longer exposed to the blood where it can cause a thrombus to form. That's because, as we talked about in the last slide, there's some scar tissue growth. There's also growth of the endothelial layer of the blood vessel, and usually this covers the metal struts of the stent so they're not exposed to blood. This makes the risk of thrombosis lower, although not zero. Patients can have a stent thrombosis years after a stent is placed. But because the risk of thrombosis becomes lower after about a year, most patients then transition from two drugs for dual antiplatelet therapy to taking aspirin only, and they usually take aspirin indefinitely for prevention of myocardial infarction. So now let's move on from stable angina and talk about what's known as variant angina. It's also sometimes called Prinzmetal angina. Variant angina has little to do with atherosclerosis. It's caused by episodic vasoconstriction of coronary vessels. So these patients will abruptly develop the onset of ischemia and angina-like chest pain. The episodes usually occur at rest, which makes this very different from stable angina. That's why it was originally called variant angina. And classically, the episodes occur from midnight to the early morning. A person who wakes in the morning with angina at rest is a classic presentation of variant angina. Sometimes patients with this form of angina even see symptoms that improve with exertion, which once again distinguishes this from stable angina. This almost always occurs among smokers, and usually the diagnosis is based on history. There really isn't a classic diagnostic test. The mainstay of treating variant angina is to tell patients to quit smoking. If they do this, this often eliminates the problem. Other treatments include calcium channel blockers and nitrates. The type of calcium channel blocker used for treatment of variant angina are the dihydropyridine calcium channel blockers, like amlodipine. These drugs and nitrates have vasodilatory properties, and they dilate coronary arteries and oppose the spasm, and usually decrease the frequency of episodes of angina. In general, we don't use beta blockers for treating variant angina, and in particular, you want to avoid the beta blocker propranolol. This is a non-selective beta blocker, and years ago, when it was the only beta blocker available, if people gave it to patients with variant angina, they would get worse, and that's because it leads to unopposed alpha stimulation, which causes vasoconstriction. Now I'm going to move on from stable angina, which involves a stable atherosclerotic plaque, and talk about the acute coronary syndromes. There are 3 acute coronary syndromes, and all of them share in common the fact that they derive from rupture of an atherosclerotic plaque and thrombus formation on that rupture. So if you look at this picture on the right side of the screen, this is an idea of what's going on in a coronary artery during an acute coronary syndrome. There's a plaque, which is the yellow here, and it ruptures and a thrombus forms, and that leads to the sudden increase in the amount of occlusion. So a vessel can go from a minor occlusion like 10 or 20% by a stable plaque to suddenly almost totally occluded because of the thrombus on top of that plaque. If the thrombus causes a subtotal occlusion, meaning some blood flow can still get past the thrombus, this will lead to the clinical syndromes of either unstable angina or non-ST elevation myocardial infarction. Both of these are acute coronary syndromes. If the thrombus completely occludes the artery, and I've drawn that down here at the bottom, this will lead to the clinical syndrome of ST elevation myocardial infarction. And in the next couple of slides, I'll talk about unstable angina and STEMI. I'll talk about STEMI in a separate video, because that's really its own syndrome. It's the most severe manifestation of coronary artery disease. And if you look down at the bottom of the screen, I've drawn two images of the left ventricle. In one image, the patient has developed subendocardial ischemia. Let's take a closer look. This is the left ventricle here, and the area of ischemia is this dark area here. And you can see that it's just below the endocardium. The endocardium is the inner layer of the ventricle. It does not involve the total wall of the ventricle. And this is the type of ischemia that occurs in unstable angina and NSTEMI. Because those patients have some blood flow, only the most vulnerable myocytes, which are the ones in the subendocardium, develop ischemia. The entire wall does not develop ischemia. In contrast, transmural ischemia is shown on the right. In this case, the left ventricle is here and the entire wall has developed ischemia. That's what happens in a STEMI. In a STEMI, no blood flow is going to the wall and all the myocytes in the wall develop ischemia. And it's because of the difference in the anatomy of the ischemia, subendocardial or transmural, that the clinical manifestations of STEMI are more severe. The definition of unstable angina is ischemic symptoms like chest pain that occur with either increasing frequency or at rest. So a patient who says, a week ago I had chest pain when I walked up the stairs, then this morning I got it when I walked across my bedroom, and now I'm having it at rest. That is the classic description of unstable angina. And patients with unstable angina must have negative biomarkers. I'll talk about the biomarkers in a minute, but if the biomarkers are positive, then the patient does not have unstable angina. They instead have NSTEMI. And in both of these conditions, you can see ischemic EKG changes, but not ST elevations. If there are ST elevations present, then it's a STEMI, and it can't be either one of these two syndromes. But there are other ischemic EKG changes besides ST elevation, and you can see those in both unstable angina and NSTEMI. So the EKG changes that are typical of unstable angina and NSTEMI are ST depressions and T-wave inversions. Let's take a look at this tracing on the screen here. This is the baseline in V5, and you can see that the ST segment is depressed, meaning it is lower than that baseline, so ST depressions are present. You can also see that these T-waves, which should be pointing up like this, are flipped. Those are called T-wave inversions, and those are also evidence of ischemia. Cardiac biomarkers are proteins that spill into the blood when there's damage to cardiac myocytes. These are detected by blood testing. The most common marker used to identify ischemia is troponin, either troponin I or troponin T. The levels of troponin I or T increase about 2 to 4 hours after the onset of ischemia, and then they stay elevated for several weeks. CKMB can also be used, although it's used less commonly in modern practice. The level of the CKMB biomarker increases about 4 to 6 hours after myocardial infarction, and it comes back to normal within 2 to 3 days. And because this comes back to normal within 2 to 3 days, CKMB can be very useful for detecting reinfarction. So imagine that a patient has a myocardial infarction and their troponin goes up. Imagine that 4 or 5 days later they develop chest pain again and you think they might be having a second infarction. Well, the troponin will still be up because it remains elevated for weeks, but the CKMB should be back to normal, so you can measure that, and if it's increased, that suggests a reinfarction. Let's talk about the treatment of unstable angina and NSTEMI. This is a thrombotic problem as well as an ischemic problem, just like STEMI, which we'll talk about in another video. So because there's a thrombus, we are going to use anticoagulants in treating unstable angina and NSTEMI, and that's different from the treatment of stable angina. Unlike STEMI, however, there's no ticking clock. So in STEMI, a vessel is completely occluded, and you must restore blood flow as soon as possible. That is not the case in unstable angina and NSTEMI. The occlusion is subtotal. There's some blood flow to the distal myocardium. So the treatment of unstable angina and NSTEMI in general does not involve emergency angioplasty, and it does not involve thrombolytic drugs. We always administer aspirin to patients with unstable angina and NSTEMI. We generally administer a beta blocker unless there's a contraindication, like hypotension or bradycardia. We almost always administer heparin, and then usually angioplasty is performed, although it is not emergent. So the patient can be admitted to the hospital and can have angioplasty within a day or so. So here's a typical course of a patient with unstable angina or NSTEMI. The patient presents to the ER with chest pain. The biomarkers are elevated. There are no ST segment elevations on the EKG, so this is not a STEMI. Medical therapy is initiated with aspirin and metoprolol and a heparin drip. The patient is admitted to a cardiac floor. On hospital day number 2, an angiogram is performed. A 90% blockage of an LAD is identified and a stent is placed. So in terms of your board exams, there are a couple of key points on this slide that you should remember. First of all, the absence of ST elevations is very important in distinguishing NSTEMI from STEMI. So you always need to obtain an EKG in all chest pain patients in the ER, and they often ask you about this on your board exams. In a patient with chest pain, as soon as they hit the ER, they need to have an EKG done, because if ST segment elevations are present, that is a STEMI and that's a medical emergency. Also, note that aspirin has a major beneficial effect in all cases of myocardial infarction, NSTEMI and STEMI. So we always give aspirin to chest pain patients who might have an NSTEMI. We don't wait for the biomarkers to come back. If a patient has chest pain and ST depressions and T-wave inversions, you want to give them aspirin right away. I'll finish with this slide and talk about the long-term therapy of patients who have had unstable angina or NSTEMI. So like I told you before, in the United States, this problem is usually treated with stent implantation. So these patients will leave the hospital free of symptoms. However, they are still at high risk of having a myocardial infarction or sudden cardiac death. So we administer long-term treatment with drugs that have been shown to reduce the mortality rate from coronary disease and reduce the risk of recurrent infarction. And the two major drugs that do this are aspirin and statin. Just like we talked about before, you give these to all patients with coronary disease for the long term, whether that patient has stable angina, unstable angina, or NSTEMI. Beta blockers are always given to patients who have had a STEMI in the past. They have a weak indication for NSTEMI and unstable angina. In general, we only administer beta blockers to patients who have had an NSTEMI, and even this is not very well evidence-based because there are limited trials. So I don't think they're going to ask you about giving beta blockers long-term to patients with unstable angina or NSTEMI. However, for patients with a STEMI, which we'll talk about in another video, long-term treatment with beta blocker is very important. And that concludes our video on coronary artery disease.